Hi, everybody, and thanks so much again for joining us today for Module 3 in this series of AHA's Conversations on Social Determinants of Health. My name is Dr. Rishi Manchanda. I'm the president of Health Begins, and this module will focus on food insecurity. We have two presenters today. First, myself. You'll hear from me speak a little bit about food insecurity in particular as a social determinant, and I will also focus on quality improvement. And I'm really privileged today to be able to be joined by Dr. Andrew Beck, who is an attending pediatrician at the Division of General and Community Pediatrics and Hospital Medicine at Cincinnati Children's Hospital Medical Center. Dr. Beck is going to give us a really wonderful presentation about some of his work and his team's work on food insecurity at Cincinnati Children's. In this module, we'll focus on a few things. First, we're going to focus on the why. What is food insecurity, and what is food insecurity's impact on health and healthcare in particular? Then we'll go into the how. We'll cover different approaches to address food insecurity, including the use of upstream quality improvement, which we've discussed in prior modules. And finally, to bring this all home, and as I mentioned before, we'll be joined by Dr. Andy Beck from Cincinnati Children's, who will walk us through what he and his fellow colleagues and leaders did to bring and apply the elements of upstream quality improvement to address food insecurity. So with that, let's get started with the why. Well, from the perspective of social determinants of health, we often can question what is the way we can view social determinants of health in a way that aligns with our day-to-day priorities, our day-to-day work. We think at Health Begins, and increasingly because of the experiences we have with a variety of hospitals and hospital leaders across the country, that the social determinants of health are relevant for intrinsic reasons, right? We know that social determinants play a disproportionate role in shaping lives of patients and communities. But we also know that social determinants are relevant because of their relationship to the triple aim, if not the quadruple aim. So again, as a recap, the triple aim, that includes patient experience. It also includes improved outcomes for entire populations. And it also includes the third aim of lowering total costs, if not per capita costs of care. The fourth aim, here on the bottom of the slide, speaks to the experience of the providers in the system, the healthcare professionals and physicians and others who are key, of course, to delivering on the triple aim for patients and for communities. And the fourth aim of provider experience really speaks to, at its essence, joy at work. We put the social determinants into this construct of the quadruple aim against a deeper backdrop of equity. We focus a lot on how social determinants of health can be a bridge that helps connect the pursuit of each of these aims, from patient experience to outcomes to lowering costs to improving joy, all back to deeper questions of how we can do so to advance health equity, both for defined populations of patients as well as for defined communities. Our work together with you as hospital leaders, with the American Hospital Association across the country, is part of a larger opportunity to improve decision-making opportunities and to improve our ability as providers and as peers to advance social determinants and equity. So the question first is, how does this actually play out in more specific ways? Why is the quadruple aim specifically related to the social determinants of health? So the first question, of course, is what does social determinants mean? According to the World Health Organization, the social determinants of health are the conditions in which people are born, grow, work, live, and age, as well as the wider set of forces and systems that shape the conditions of daily life. It's important to note that in the World Health Organization's definition, which is something that particularly appeals to us at Health Begins, that these forces that shape the conditions of daily life and the systems in which we operate, they include economic policies and systems, development agendas, social norms and cultures, as well as the policies and political systems around us. So with that definition of social determinants in mind, let's think about how they relate to each of these elements of the quadruple aim. And as you can see here, in our experience, we've seen time and again that social determinants of health relate to each element of the quadruple aim. We've seen that patients for whom issues like food insecurity are not addressed have a harder time experiencing trust and receiving high quality care when the system that they're receiving care from doesn't understand, if not help address, food insecurity as it impacts their health. We also know, of course, that without addressing a root cause like food insecurity or other social determinants of health for populations of patients, it's harder to achieve better outcomes. We also know increasingly, of course, in this era towards value-based payment, that social determinants of health are linked to the drive to lower per capita and total cost of care. And without doing so, of course, then we may have missed opportunities to be able to do exactly that. Without addressing social determinants of health, in other words, costs might continue to rise in unsustainable ways. And finally, and perhaps most importantly for a lot of folks who are listening to this today, as physicians, as providers, as leaders in hospitals, what we've seen time and again is the fact that the ability to actually work in a system that can better understand social needs and then help connect individuals who have those social needs with appropriate resources in the community, the ability to work in a system like that, in an upstream aligned system, is really critically linked to the joy of professionals working in it. We know that provider experience, with literature that continues to emerge these days, is really linked to the sense of one's own capacity in their system, in their team, to address social determinants of health. In other words, joy at work might itself be linked to social determinants of health in really profound ways. So for us, the social determinants of health are linked to the quadruple aim, are linked to each of these elements, including a greater backdrop of equity in really deep and profound ways. So with that global context of social determinants of health and why they matter to each of the elements of the quadruple aim in mind, let's do a little deeper dive on food insecurity. What is food insecurity? Many of you have probably already started thinking about ways to address food insecurity in bold new ways. Here's a definition of food insecurity so that we're all grounded on the same page. As the USDA has articulated, food insecurity is a household level economic and social condition of limited or uncertain access to adequate food, with either disrupted eating patterns or reduced food intake. One of the things that I personally take away from this, and I wanted to communicate to you, is that food insecurity is a household level phenomenon. It is not hunger. Hunger is really an individual level physiologic symptom. It's a sensation that is often, of course, linked to household level food insecurity. So if we think of food insecurity as a household phenomenon, hunger is an individual experience. And of course, they're very much linked, but it is important to understand that distinction as we move ahead. Well, when we think about food insecurity, again, this household level phenomenon, we know that it has many faces. The statistics are actually pretty sobering when we review them. According to the USDA, nearly 17 million households, or about 14% of all households in the US, have experienced food insecurity at some point. And this is according to 2014 data. The data more recently that we've seen are not too far off the mark. This means that during at least some point in the year when the survey was administered, households lacked access to enough food for each member of that household to live an active, healthy life. We also know that there are a variety of programs that exist that can help address food insecurity, and some of these are very familiar to those listening today. These include the WIC program. They also include school meals. There's a variety of summer feeding programs for school-age children. And of course, then there's the Supplemental Nutrition Assistance Program, SNAP, or formerly known as food stamps. And there's also a variety of other programs that provide food assistance that are linked to child care services. With this in mind, we can recognize that as a healthcare community, we know that food insecurity, this phenomenon, this household level phenomenon that clearly impacts many households around the country, and that is being addressed in a variety of different ways, that this has real direct impacts on the health of individuals. Food insecurity, in a nutshell, is harmful to an individual. So we know it's harmful for both adults and for children. For children, it can be particularly devastating due to their unique physical and developmental needs. For adults in food insecure households, the research tells us that there's an increased risk for high blood pressure, cholesterol, heart disease, type 2 diabetes, and a whole variety of other health conditions. So we've reviewed the statistics about food insecurity. We've talked about its globally, its prevalence in the U.S. and also its high-level impacts on health. The literatures are replete increasingly in these days as more and more research comes about the impact of food insecurity on the health of populations. But let's put this into more context by talking about what it means for one particular patient. I wanted to highlight the story of Mrs. M. And this is going to really be a touchstone for our later conversation with Dr. Beck. Mrs. M is a 46-year-old mother of two. She also cares for her frail mother who lives with her. Mrs. M has type 2 diabetes. It's not well controlled, unfortunately. Her last hemoglobin A1C was 8.1. Mrs. M holds down a job. She takes care of her two kids. She takes care of her mother. She takes care of all the basics of rent and food, utilities, etc. She works hard at making ends meet and also being there for her family in the way that their family needs. At the end of the last month, while she was at work, her coworkers noticed that Mrs. M seemed very faint. She nearly fainted, in fact, and the paramedics were called. They brought her to the local hospital, perhaps the hospital where you work, and she was admitted. And after an extensive workup, the cause of her admission was found to be low blood sugar, hypoglycemia. This is unfortunately a far too common story. As you hear Mrs. M's story, perhaps this provokes some memories of patients that you've had the privilege of serving as well in your own institution. I ask you to think about that patient, the person that comes to mind as we talk about Mrs. M, to think about the real face, one particular face of food insecurity, to really make this accessible, to make us realize that this is not just an overwhelming phenomenon and a non-healthcare related phenomenon, but one that impacts patients like Mrs. M and like the ones that you're thinking of day to day. And with that in mind, with Mrs. M's face now in mind, let's understand exactly what may have happened over here. And in Mrs. M's case, it was food insecurity that was the ultimate root cause for, or the addressable root cause, we think, for what led to that hospitalization. And this is not a unique phenomenon. As we see on this slide, food insecure adults are nearly 3 times more likely to have diabetes than food secure adults. And that's even after controlling for important risk factors, such as income, employment status, physical attributes, and lifestyle. The research is telling us that food insecurity itself may be an independent determinant of the development of diabetes. And we're seeing this now reflected in some of the correlations we're seeing in diabetes prevalence along with food insecurity. We see diabetes prevalence rising as severity of food insecurity increases across the country. So it's interesting that food insecurity now, as more and more of us in healthcare become aware of this phenomenon, are recognizing that food insecurity itself may not just be correlated with diabetes and other conditions, but may be a driver of the development and the worsening of conditions like diabetes in the first place. So there's certainly these are early days as we're learning more and more about this social determinant of health of food insecurity. But suffice to say that in thinking about Mrs. M and thinking about these statistics overall, the reason this matters, why food insecurity is important for health and healthcare, can be thought of through the quadruple aim in the ways I've described, and it can also be thought of just through the story of an individual patient. And I encourage you, as we think about the why, as you think about how to engage your peers, to either use the conceptual model of the quadruple aim or to use the individual story of a patient like Mrs. M to be able to communicate the why this matters. So clearly, food insecurity is having major implications. It really matters for all the reasons we mentioned. With that, let's pivot now from why it matters to how we do something about it. Let's talk about the how. And as we've discussed in Module 2, a module that focuses specifically on upstream quality improvement, this is one method in particular that we are a big fan of. We've actually been promulgating and supporting in a variety of different settings across the country. It's a method of upstream quality improvement. This represents the merging of quality improvement with the knowledge and expertise and resources that exist upstream in the social sector. There are organizations that address things like food insecurity, food banks, etc. And all of these organizations are generally participating in varying degrees in a variety of different quality improvement initiatives as well. Certainly in hospitals and healthcare settings, we've become more familiar with quality improvement and have shown that that method can lead to high performance, can lead to decreasing variation in care, can lead to improvement in outcomes for patients. It can lead to advancing the triple, if not the quadruple aim. But we also recognize that there's a lot of quality improvement efforts that are happening now, activities that are happening in the social sector. What we call upstream quality improvement is really the blending of quality improvement work that we do in the healthcare setting with the quality improvement initiatives that are happening upstream, and the pursuit of ways to leverage both of those activities in both sectors at the intersection to address social determinants of health in partnership. That's upstream quality improvement. So with that term in mind of upstream quality improvement, let's go back to the basics of quality improvement. And we'll hear soon from Dr. Beck, and he'll describe how some of the elements of quality improvement have been so effective in helping his hospital to be able to address food insecurity. So we know that QI itself starts with 3 fundamental questions. First, what are we trying to accomplish? Second, how do we know that changes are an improvement? And third, what changes can we make that will lead to an improvement? One of the elements of quality improvement that, as a physician executive, I found particularly important to review is, of course, that it's not just about those three fundamental questions. Quality improvement also is represented by a variety of different, really incredibly helpful tools. One of those tools is a run chart. No doubt you're using run charts, but I wonder if, as a hospital leader, you yourself have thought about using QI tools such as run charts to address issues like food insecurity in your own setting. We're soon going to learn from Dr. Andy Beck about how he has applied them in his hospital. We know that run charts allow you to do a few things in the quality improvement context. They first help you to see how well a process is working. Second, they let you see if there's been a real improvement by looking at data, for example, looking at trends or shifts. And thirdly, run charts can inform the direction of your improvement approach, not just to concepts in general, but in this case, to social determinants like food insecurity, as it tells you which changes were more valuable or impactful than others. So what could all of these things look like if you're using them in your own upstream quality improvement campaign to address food insecurity for patients like Mrs. M in your setting, in your hospital? We ask you to think about that, and as you do so, to think about how, again, a QI approach, an upstream QI approach in particular, can help you define goals, track improvements, implement changes, but also help you tell a broader story about improvement to your colleagues and to other key stakeholders. Those can include your partners in the community, your champions and executives within your system, as well as to your patients. So upstream quality improvement is not just about methods to be able to drive improvement. It's also about a way to be able to tell an improvement story. And this is especially important for hospital leaders who are trying to move upstream, who are trying to implement changes that can address social determinants of health. So with that review of why food insecurity and social determinants matter to health and healthcare, and the review of how we can do something about it using upstream quality improvement, we want to hand this over now to Dr. Andy Beck from Cincinnati Children's Hospital to help us really illustrate and bring to life what this approach can look like in practice. So with that, I'm pleased to introduce Dr. Andy Beck from Cincinnati Children's Hospital Medical Center. Andy, it's all yours.
Thanks so much for having me today, and thanks so much for the opportunity to present some of the work that we feel is so important as it pertains to our population health efforts here at Cincinnati Children's. By way of introduction, I'd like to describe a little bit about both the hospital in which I work as well as the vehicle through which much of our population health efforts occur. So let me start with Cincinnati Children's Hospital. We are a large urban and academic pediatric care system that can be very specialized in many of the things that we do. That said, our vision is to be the leader in improving child health, whether it be in pediatric subspecialties or in primary care. We are a population-level hospital-based care provider, which means that any child from within our general region comes to us. And importantly, we're the primary care provider for approximately 35,000 patients. These patients are largely underrepresented and underserved, with roughly 90% covered through Medicaid, and 70% are underrepresented minorities. Given the degree of need present within this population, we have a long history of strong academic community partnerships that we have directed towards social determinants of health, much of which I'll talk about today. Now, given the hospital's reach, we've also driven ourselves to be committed to population and community health. The primary vehicle through which this occurs is the so-called All Children Thrive Learning Network, or ACT. This is an academic community alliance, again, whose express purpose is to drive population health equity, and has the vision to help ensure Cincinnati's 66,000 children are the healthiest in the nation through strong community partnerships. Now, we know that to achieve such lofty goals, we must optimize both the medical and social care that we provide. And much of that care requires us to think critically about the social determinants of health. One especially important social determinant of health is food insecurity. Food insecurity refers to the uncertainty surrounding either access or availability of food. And lots of data, lots of evidence have pointed to food insecurity leading to malnutrition or disordered nutrition, increased rates of acute infections, poor general health, and higher risk for adverse outcomes like developmental delays, behavioral problems, or mental health diagnoses. one of my colleagues conceptualized food insecurity according to Maslow's hierarchy of needs. This figure that you can see on this slide is a depiction of that reality. Many of you are probably familiar with Maslow's hierarchy, and we know that at the base of the pyramid are those physiologic needs like shelter, warmth, and food that we all require to allow ourselves to ascend the pyramid and achieve our full potential. What my colleague, Dr. O'Malley, thought was that if you had insecurity or insufficiency of any of those three, it was almost like a three-legged stool, prompting the rest of the pyramid or hierarchy to topple over. Thus, food insecurity is critical for our population as they seek to achieve their full potential and their optimal health. Because of our population, especially in primary care, we became very interested in how we might confront food insecurity in our pediatric primary care setting. This led us to define a priority population, and initially we began with a focus on food insecure households with infants. Again, a high-risk population that we see over and over in our pediatric primary care setting. We wanted to quickly move toward action, knowing the importance of food insecurity on health outcomes that start early and stretch across the life course. And given a culture of quality improvement here at Cincinnati Children's Hospital, we actively employed these methods in the assessment of need, in the development and implementation of screening practices for food insecurity conducted during primary care, and then the implementation of an intervention to connect those that were identified as at risk to a rescue supply of formula and potentially other resources too. We included within this supports for breastfeeding mothers if a child was found not to be on infant formula. And then ultimately, with any good quality improvement project, we sought to rapidly move towards scale and spread. Now, importantly, as something we can discuss a little bit as we move forward, the role of the physician in this project evolved as time went on. Although we started as frontline individuals important to the actual implementation, we've evolved into something more high level towards stewardship and strategy to support scale and spread. But let me walk through each of these individual components and illustrate how we pursued them and how we used quality improvement to optimize our effort. And let me start by the assessment of need. Early on in our project, we opted to do a needs assessment, and this involved background surveying of clinic families. Pretty quickly, we found out that food insecurity was a real problem, particularly among households with infants. Indeed, roughly 31% were identified as food insecure using validated questionnaires from the USDA. Moreover, we found that 15% of households with infants stretched their formula, especially at the end of the month, to help make it last. We also unearthed challenges related to food access, budgeting, and making both money and benefits like WIC and food stamps last over the course of a month. Complicating this was skepticism of generic branded infant formula, even though we know it to be 40 to 50% cheaper when bought out of pocket. This pushed us, of course, to think more deeply about food insecurity-related equity gaps, as well as to make screening a part of standard care. I did want to show this concept of equity gaps related to food insecurity via these two pictures on the right of the slide. If you think about different individuals as they go to purchase nutrition, we can think about different barriers or supports that one might face. If you look at the top panel, the person on the left is at a grocery store filled with plentiful organic produce. The person in the middle perhaps has less of a supply and they have to carry their purchases in a handbasket. And then the person and her children on the far right are looking at less nutritious supply and even more difficulty in carrying their purchases. This extends to the bottom panel when the families return back to their home. One has a comfortable car that can easily handle the purchased food. Another rides the bus and may have a little bit more difficulty in carrying their purchases home. And the final is a family that's on foot, carrying both a child, holding the hand of an older child, and carrying bags of food as they go. Again, the reality for so many of our families and part and parcel to the concept of food availability and access. So with this in mind, we moved rapidly towards screening. What you see here are a couple of panels that I will walk you through. And I'd like to start on the right of the slide with the questions that we now ask within our primary care setting. You can see here 2 questions that have been published as being a validated screen for food insecurity that we've opted to use on a routine basis in our primary care setting. And what we sought to do early on using quality improvement methods was to increase the rate, not just of screening, but of food insecurity identification within our primary care center. As with many good quality improvement aims, we quickly developed our theory using the concept of key drivers, thinking that we needed an evidence-based criteria for food insecurity identification, that being the 2-question screen above, awareness of food insecurity in our population by key stakeholders, effective screening for sensitive topics asked in empathic and sensitive ways, empowered providers not only to ask but to act, and then buy-in not just from providers but also from the families that we were seeing in our clinics themselves. We also tracked our efforts via time series, that's the figure on the left, highlighting that over time we went from food insecurity identification from 1 to 2% all the way to 11%. Now, this time series figure is a run chart commonly used in quality improvement. The y-axis represents the percentage of families that we were seeing in our clinic that were identified as being food insecure. And the x-axis is time measured in weeks. Each dot represents the rate that we saw for a given week. And you can see annotation of certain tests of change that were employed over the course of this period. Of course, screening was just part of what we opted to do and what we wanted to do. Ultimately, we wanted to connect to resources. This formed the onset of the KIND program, which is entitled Keeping Infants Nourished and Developing, which is an academic community partnership between Cincinnati Children's and the Free Store Food Bank, which is the largest regional food bank in our area. This program was developed several years ago around the time that we were enhancing our screening, and you can see a similar run chart on the left here, illustrative of when KIND started. Here we were using this time series, this run chart, to assess the number of formula cans distributed, which served as a proxy for the number of families impacted by our program. You can see some annotations of our tests of change, and you can also see some of the early data about how effective we were at the onset of this program. Now, to date, we know that at least 5,000 households have been assisted through KIND with on-site formula and resource connections. We have data to suggest that this has led to increases in primary care sensitive preventive service completion, including lead and developmental screening, completion of a full set of well infant visits and associated immunizations, connections to on-site resources like social work and our Med Legal Partnership, as well as off-site programs like those offered by the Free Store Food Bank. And we've also seen an increase in awareness on the part of our families, but also our providers, about the use of generic branded formula when buying out of pocket. Given that we're an academic health center, we've also included this as a key component of resident education, ensuring that our providers pursue empathic screening and action on the social determinants of health during routine care, and also see food insecurity and other social determinants like it as bridges to other social needs. As we developed it, we also had an eye towards scale and spread. Over time, we've taken KIND and in partnership with the Free Store Food Bank, moved it to now more than 10 primary care centers and subspecialty clinics across our region, enhancing collaboration to reach additional age groups, as well as potentially meet more need through ongoing projects that we now have in place related to in-clinic pantries, community-based produce delivery, and pattern recognition around key policies that are of relevance to food insecurity, including legal advocacy around the onset and timing of WIC and SNAP benefits for newborn babies. We've also used this as a model for other academic community partnerships poised to address social determinants of health and tried to link it to our strategic spread of academic community partnerships across our region. The map you see on the left of this slide includes the counties that are served by the Free Store Food Bank. The color of the counties represents the child food insecurity rate for those counties served. And what we've importantly done here is overlay not just these data, but also a series of dots that include both food pantries as well as primary care providers across our service area, illustrative of the geographic proximity as well as the proximity in terms of mission. Now, I alluded to this a moment ago about our desire to spread towards other populations and other connections to needs. And one of the key focus areas which we are pursuing now relates to clinic-based food pantries, with express goals to bond families to their primary care home in ways that increase trust, as well as to serve to meet medical and social needs together. We also are aiming to address care gaps in high-risk families and meet them more effectively where they are, and ideally creating linkages to social agencies to address those root causes of both adverse medical outcomes and adverse social outcomes. The picture you see on this slide is our first in-clinic pantry. It's been open approximately 1 year and has been used by now over 700 children and parents, with early evidence of enhanced connections to both resources on-site, subspecialty resources at the hospital, and social resources in the community. I included a few qualitative quotes from families that have made use of the pantry over the course of the last year. One noted that it opens the door. I now feel more comfortable asking for help if I find myself in a situation where I need assistance. Another said that we sent the lease document to SNAP and now have the food stamps we need. Again, here the clinic served as an initial starting point for assessing need and figuring out how to more effectively seek a long-term solution by helping this family sign up for SNAP. Finally, a family noted that the food held us over until my food stamps came 1 week later. It was the right amount at the right time. This pantry and kind in general were developed along the phased pathway that I illustrate on this slide, a real framework to support academic community collaboration. Now, I don't mean for these phases to necessarily occur linearly, but we found that there's great value in thinking about them as we plan both onset of intervention, scale of intervention, and ultimately spread. As you can see, moving from phase 1 to phase 5, we really think about those key clinic or partner-based challenges related to funding, provider or partner engagement, necessary infrastructure, and critical integration of operations. At the same time, we must consider family-based challenges and ensure that what we do supports parent and family engagement as well as follow-through. In an ideal world, and in a way that we are trying to build upon now, solutions are co-designed with families so that they ensure they are meeting the needs of our end users. Now, of course, our work has been met with challenge. No work like this is easy, and I think we've seen challenges from program onset to program spread. Early on, we experienced some pushback around the appropriateness of providing formula within the clinical setting. Does this detract from our message around breastfeeding? Are we in the social service business? Will there be a deluge of individuals coming to our front door with the desire for formula? Some of these questions were planned for and led us to think critically about how we would effectively message our intervention for breastfeeding families. We also thought about what our mission was in terms of trying to achieve the best health outcomes for our children. Seeing that food insecurity had a relevance helped us to answer the question about what business we were truly in. And we also developed contingency plans to ensure that if we did have more people showing up, we knew what we would do. Second, we really felt, especially as we moved towards scale, about the loss of focus over time. We have a busy academic clinic, there are lots of learners, there are a lot of providers, and lots of turnover. And so we've found the need to have a strategy for sustainability at each step along the way. And finally, as we moved towards spread, we found that we needed to cede control to other sites while ensuring that the program had maintained fidelity. So it forced us to think about what are the essential aspects of the program and what can be adapted to meet the needs of different sites and different populations. Now, of course, with these challenges came many lessons. Of course, as I mentioned before, we planned for contingencies. Small-scale tests using quality improvement methods helped us to unearth unanticipated consequences. And insights were gained from key stakeholders, including end users, patients, and families along the way. We also ensured that we had strategic alignment with organizational priorities, both at Cincinnati Children's and the Freestore Food Bank, illustrating at each step that addressing the social determinants of health, those other upstream factors, can indeed support child health and well-being. And of course, to use the lexicon of quality improvement, we've tried our best to not lose sight of our aim and our objectives. We had clarity of our SMART aim, we had developed key drivers to outline our theory, and we had consistent measurement and evaluation of our key processes and outcomes. So just in the way of a brief conclusion, I hope I've illustrated that food insecurity is, one, a key social determinant, and two, has critical implications both short and long-term with respect to health outcomes, and can also be a key bridge to other social determinants of health, like housing, transportation, and access. I'd also suggest that not addressing food insecurity and other social determinants of health will perpetuate suboptimal outcomes and widen disparities. We found success using quality improvement as a change tool, one that helped drive action and helped us to accelerate toward achievement of a specific objective. And in line with the oath that many of us take when we begin our career, we've come to understand that as physicians, we have a special obligation not just to our patients, but also to improve population health outcomes and narrow equity gaps along the way. I'll close by illustrating some references that were alluded to in this presentation, and then I look forward to our conversation.
So Andy, thank you so much for what a wonderful presentation that was, especially being able to highlight both food insecurity, the project itself that clearly has had such an impact on the lives of children and families in Cincinnati, and the really important mention of quality improvement as well. There's so much here that I think we could discuss. I thought I'd lead us off by focusing on your role as this project started and evolved over time. Can you give us a bit more sense about how your role as a physician leader evolved through the various stages of this project?
So I think there's certainly been a great evolution there. I think early on, as we were finding our way, myself and my colleagues who helped to start this program were really hands-on. And when I say hands-on, I mean hands-on. We were the ones who were driving to the Freestore Food Bank, picking up pallets of formula and driving it back to our clinic. And I think that was part of our learning. What would it take for such a program to get off the ground? What was feasible? What was not feasible? And although that was really effective for small-scale tests of early change, we knew we needed to develop a system that was more seamless and more responsive and didn't rely on just a few of us. And so pretty quickly from there, we went from being kind of the hands-on drivers, both literally and figuratively, to being those more in line with strategy and development of sustainable processes. And so I think as we moved from program onset to sustainability and ultimately to scale and spread, it went from us being kind of the ones driving the process to being the ones strategizing, measuring, and evaluating the process.
It's such a wonderful representation, I think, of that evolution, as you said, both as a leader as well as what it means to kind of track with a quality improvement experience. I want to pivot in a moment to the quality improvement, but before we do so, this concept of evolving roles as leaders is relevant in the way that you just made clear, Andy, for yourself and other physician leaders. Could you reflect on, as your roles as leaders evolved, as frontline champions and then the stewards of the processes, and finally then the kind of drivers and the overall kind of shapers of strategy? How do the roles of other leaders, both within the hospital and even among your community partners or the alliance that you mentioned, how did those start to evolve as well?
So I think the short answer is yes. I think as well as community leaders have evolved over time in line with, if not evolving missions, at least missions that have been coalescing. And so as an example, some of this work specifically has been paired with other elements of work both within our hospital, within our healthcare setting, as well as within our broader community around child health and well-being. And so as our hospital's mission has focused still more and more on optimizing the health of our patients and optimizing the health of all children in our region, we have seen how that complements the mission of so many key leaders out in the community, whether it be at the Free Store Food Bank or other agencies across our city. And so I think as the missions have crystallized and coalesced, it's changed a little bit the roles that we've seen ourselves playing both within the healthcare setting as well as within the community to enhance our focus on, say, health as opposed to healthcare, which clearly intersects with this concept of what is our role within those upstream factors to ideally prevent the downstream outcomes that are suboptimal.
I think this really illustrates something that we've been seeing and observing and celebrating, actually, in the fact that leadership, especially when it comes to upstream changes in the way that you're exemplifying, Andy, kind of the leadership is not a commodity. It's not a static phenomenon. It's a constantly growing and evolving skill and sense of professional place in the world, right? It's always evolving, and it has to be responsive to the environment.
If I could just add one more thing to that, because I think that's a really important point. Is that one of the things we've really grappled with and lived over the course of the last several years is when to be a leader and when to be a partner or collaborator. And I think that becomes especially apparent when we get into the fields that we're talking about. I don't claim to be an expert on food insecurity or distribution of food via food pantries across the city. I claim to be an expert on child health. And I think where that intersects, I can be a leader, but I can also know when my role is to bring my expertise on child health to a different venue and support leaders within that venue, if that distinction makes sense.
It absolutely does. We like to think about, and I think what you're helping me think of, Andy, is this notion of leadership as the ability to understand when to lead, when to partner, and when to support, and when to know the difference between those. Well, we are talking about social determinants of health and the importance of environment. I'm wondering about what elements in your hospital's environment or in the community kind of partnership, the environment of that relationship, in the culture, in the structure of the hospital, or even the systems that you used, enabled you and others to evolve and grow in the kind of leaders that you described?
I would point to three main things that we have at Cincinnati Children's that have really supported us within this work. The first is an institutional commitment to quality improvement. So QI is pervasive here at Cincinnati Children's. It's just ingrained in our culture. And so that, I think, is number one. Number two is that we as an institution in a city of our size have a relatively unique situation in that we truly are a population provider, at least for hospital-based care. This, I think, presents to us a greater responsibility for the concept of population health. So we truly feel a responsibility not just to the kids who may walk through our door for primary or subspecialty care, but also to our city and our region for health more generally. And the third thing that I would say, which I think clearly ties to 1 and 2, is that we have a history of academic community partnership that has supported our work in quite meaningful ways. And I think that the elements of what we've experienced with the Free Store Food Bank are a good illustration of this, but are not the only place where we have seen the collective value of coming together in partnership for a common mission.
Those three elements, Andy, the institutional commitment to quality improvement, the greater sense of responsibility to address population health, and then the last element of the history of the type of academic community partnerships, the history of those partnerships, I think is really really helpful. It illustrates, I think, how important it is to understand what key enablers need to exist in an environment in some situations to enable a project like this to succeed in the way that you've able to demonstrate. You mentioned quality improvement, that first criteria, so I wonder if we can spend a moment just talking about a bit more about that. You clearly illustrated that quality improvement played an important role in this project. I'm wondering if you could speak about what elements of QI were most helpful to your hospital-based team, and similarly, if you could reflect a little bit more on how, if at all, QI was helpful with your community partners. It'd be great to understand which elements in particular. You've talked about the run charts and a few other specific tools. Were those really helpful, or were there other elements of quality improvement that were especially helpful in being an effective tool to drive action?
Right. So I think I would say that there's kind of the entirety of the QI toolbox that can certainly help us to drive improvement in meaningful ways. I think when we think about what was most helpful to us as the hospital-based team, the certain things that I often think are most helpful are coming together around a so-called SMART aim, which allows us to say this is what we strive to accomplish, this is how we're going to measure it, this is when we strive to accomplish it by, very specifically so we can all be on the same page with what we're trying to do. That then naturally leads into a measurement strategy, whether it be through run charts, control charts, or something still different, to ensure that we can track along with that with the progress that we're trying to make. And so those are probably the generally speaking, the tools that I think were most helpful to us as we built KIND, and have been critical to us as we've pushed our other population health efforts and community partnerships through the All Children Thrive Learning Network. I think the other thing that I would add to that is this concept of co-design or co-production. One of the things that quality improvement helps or has helped us do, and I would argue could help others do, is to come together around a common language. So we are collectively going to work to improve this or solve this problem. This is how we're going to measure it. This is how we're going to do it together with this theory for action.
So Andy, clearly, quality improvement has been helpful. You've mentioned how it's been important to provide a common language for stakeholders, both within hospitals and across your partners, including community organizations. It's helpful as a way to be able to clarify what the aims are, and then to be able to use certain tools like run charts and control charts to be able to then measure the progress against those aims. I'm wondering if, based on that experience, you think other hospitals should use QI more to address upstream issues? And if so, are there ways in particular that QI needs to be looked at with different eyes? Are we using QI fully in this new realm of social determinants of health?
So I think to start, I would say that there is certainly a role for quality improvement in addressing population health and in figuring out what our role is with respect to the social determinants of health. And I think the first question any hospital or physician leader must answer is, what is it that you are trying to accomplish? And I think if the answer relates to a global aim of helping our patients, our populations to thrive and be the healthiest that they can be, the social determinants are clearly going to be an aspect of that. And I think what quality improvement can help us with is figuring out a theory for how we can add measurably to action on the social determinants, how we can alter our processes in meaningful ways to drive the best possible outcomes, and how we can measure those changes over time. And I think the use of quality improvement with that kind of clear set of questions about what are we trying to accomplish and how are we going to know that we've accomplished it can really be greatly accelerated by certain steps like aim development, theory development, and delineation of key processes and outcomes that can be measured in very specific ways.
Well, Andy, thank you so much for this conversation today, for your presentation, and of course for this question and answer dialogue here. I really think that a lot of folks in the American Hospital Association network, especially physician leaders, will be looking at your example and the example of this great work at Cincinnati Children's for a lot of inspiration and a lot of really specific, concrete ways and ideas for them to move upstream in their own settings as well. I want to thank you for your time. Thank you for your work, of course, and look forward to determinants of health. Thank you so much for joining today's module on food insecurity. We hope you have a better understanding now of food insecurity and its impact in relationship to healthcare. Have a better understanding of how to use various tools of leadership, including quality improvement, to be able to address food insecurity, and then have a better sense of how this could be implemented in your own hospital settings based on the presentation from our presenter today, Dr. Andy Beck from Cincinnati Children's Hospital Medical Center. Thank you all. Looking forward to helping and watching all of you on your journey upstream to improve social determinants of health and especially food insecurity. Thank you. Next recording.